Good morning. Good morning. We were betting who was going to have to go after Bill. Phil got the short straw, so I'm glad about that. Welcome to Philadelphia. Now, I was told I have 13 minutes, and that I was supposed to talk about barriers, and I was talk about lessons learned, and I was supposed to talk about a lot of other things. So it's going to be somewhat of a challenge, but what I thought I would do in the short time that I have is to talk about practical things that people who are struggling with taking what Bill White talked about this morning and translating that into a system of care. And some of the struggles that we've had in doing that, both in Connecticut. I was in Connecticut prior to coming to Philadelphia, and had the pleasure of working with Tom and with Phil and a lot of other great people there. And what Bill said about systems transformation being messy is so true, and I think all of us who struggle with trying to transform systems that have been locked in a certain way of doing business for years, to transform them into behaving differently is a huge challenge. And one of the things I learned from Tom Kirk, who I consider a mentor and who has had a tremendous influence on my thinking as a policymaker, is that if we are serious about transforming systems, we cannot tinker around the edges. And he took the position early on that if we're going to transform the system and move it to a recovery orientation, we're going to do it fundamentally around everything that we do. And that's the approach that Connecticut has taken. That's the approach that we're trying to take here. And so what I thought I would do is talk about 5 lessons learned, sort of the top 5, do the David Letterman thing. I know he does 10. Those of you who watch David Letterman. I'll take the top 5 that I've learned in terms of trying to do this work. And before I start, just to give you a couple of examples, because I won't be able to give you, everything that we're doing, but just to give you an example of the kind of translation work that we're trying to do. So one of Bill White's concepts is that we have to look at access and how people access care. And so we've tried to implement multiple strategies to do that. So that's why we do a faith-based initiative, because there are many, many people who will never walk into our treatment programs. So they will go to their mosque, or they will go to their church, or they will go to their pastor, and that is their way of getting help. And what those people tell us consistently is that when people come to us and say, I need help, they don't know where to turn. And so they are waiting for us. They have been very receptive to us coming out and doing presentations. We will do a process where we will have the church, or masjid, or temple invite the providers from that community, other churches or other faith institutions from that community, and we use that as a way of connecting those individuals to people who are next door to them in their community, and that has been very effective at creating another portal into the treatment system. And there are other strategies, NIATEX and other kinds of things. Or the aftercare, now working with Tom McClellan and Jim McKay around telephonic aftercare and wanting to implement that. So let me give you the top 5 things that I've learned in terms of systems transformation. At the top of my list would be conceptual clarity. And what I mean by that is, when you say a recovery-oriented system of care, if I were to ask 5 people in here, what does that mean? I would probably get 5 different answers. And if you say that within your system and say, we're going to do a recovery-oriented system of care, and people aren't clear about what you're talking about, it is counterproductive and you waste a lot of time and so forth. So let me give you a couple of examples. We first started talking about recovery-oriented systems of care. People would stand up in the audience and say, well, I don't like this evidence-based practice stuff, because evidence-based practices are antithetical to a recovery orientation. It's too rigid. It goes against what we're trying to do in terms of recovery. Or I would hear providers who would say, well, what we do is treatment, and if you're going to fund this recovery stuff, don't do it at the expense of treatment. I'm telling you what people, you got to know what people are thinking, right? Right? And so, we spent a lot of time making sure that we were clear about what we meant. So both in Connecticut and here in Philadelphia, we said, look, evidence-based practices are a fundamental part of a recovery-oriented system of care. Our rationale is that you cannot help people engage and initiate treatment if you're not using the best of what science tells us works. Why would I want to go into substandard care? And so we integrated that idea. The other issue that people say, well, you want us to pay attention to trauma, you want us to pay attention to co-occurring, you want us to pay attention to this, and recovery is just another part of a long list. And so, again, what we had to say to people is, look, recovery is an overarching framework. It's a way of thinking. It's a way of organizing our system of care. But if we're going to be effective at doing that, we have to deal with the issue of trauma. Because if we don't help people with trauma, we know, those of us who have been clinicians, we know that that gets in the way of people's recovery. We have to deal with co-occurring because that is critical to helping people in recovery. So having a clarity about what it is that we're talking about when we're talking about a recovery-oriented system of care and helping people to integrate the various concepts and various things that you're doing is, I think, enormously important. Saves a lot of time, and you don't get into that, well, this really doesn't fit, or you're asking us to do another thing, or I do treatment, why are you bothering about recovery? And by the way, I think that's a really important thing because one of the things that I hear often is that the idea that recovery is something that happens after treatment, right? That recovery happens after treatment. And if we as policymakers aren't very clear that the money that we spend is in the service of people engaging in recovery, it lets a lot of folks off the hook, and we don't use the leverage and resources that we have to move our system. So number one is having conceptual clarity, and there's one other point that I'll make about this. Conceptual clarity cannot be something that policymakers promulgate on their systems, I don't believe. It has to be a process where people come together and there's consensus built. And I think one of the reasons that it worked well in Connecticut, I think it's working well here in Philadelphia, is that it has been a collaborative process from day one. The recovery definition, what's included in our concepts, all of that stuff. So we don't fight about those things because all of us agreed on this is what we were going to do, this is the map, this is the road plan. And so conceptual clarity, number one. Number two, and I think is just as important, is the idea of parallel process. How many people in here are clinicians? Right? So when I say parallel process, you know what that is, right? Right? So how we treat our providers and executive directors, I think, has an impact on how they in turn treat their direct staff, and has an impact on how they then treat the people that they're working with. And so one of the decisions we made early on was that we were going to not only talk the talk, but we were going to walk the walk. And if we wanted providers and direct care providers, service providers, to have an approach of openness, an approach of partnership, of respect and dignity, we had to treat our provider world like that. And so we worked very hard at being respectful to providers, listening to providers, treating them with dignity and respect, and not doing gotchas, which is something that those of us in policy do sometimes, and just being honest, I've been on both sides. Because we think that that sets a tone for the system, and that makes a huge difference then in how providers can run and manage their systems. Being transparent has turned out, there are a lot of counterintuitive things that I think happen in trying to transform systems, and I think one of them is the power of transparency. When people understand how we make decisions about how money is going to be spent, and all of a sudden someone doesn't see provider A just got a $500,000 contract, how did that happen? Everybody knows how it happened because they were part of the process. Or we're very clear about the direction that we're going, and people don't feel blindsided by a new initiative. That makes a huge difference, I think, in the level of trust and our ability to work together, which is, I think, critical in trying to right or change a big ship or a big system. Number 3 is the notion that if we are serious about changing systems or organizations, we have to develop the infrastructure to do that. I think one of the smart things that Tom Kirk did in Connecticut was, when he decided that we were going to move to a recovery orientation, he said, I'm going to have people who are dedicated to doing this. In fact, that was me. I had like a staff of 1 or 2 in the beginning. But that was so important because that staff then became essentially a think tank. You cannot do this work if you have 25 other things that you're trying to do. It will not happen. And having operational responsibility at the same time that you're trying to do the kind of conceptual heavy lifting that I was talking about and the implementation just doesn't work, in my opinion. And so one of the first things we did when we started this in Philadelphia is we created a strategic planning unit. We dedicated staff. Your job, your only job, is to figure out how we're going to change this system. I think that made a huge impact on our ability to get traction early on and to begin implementing things within a reasonable time frame. One of the neat things that's happening now is that while we started with a small group of people who are dedicated to system transformation, we try to be strategic about expanding that so that the whole organization is focused on that. And so we asked everyone in the organization, IT, finance, everyone in the organization, to develop what we call recovery unit plans. So within your unit, tell us how you're going to redo your business so that it is helping us with our goal of recovery. I had this really great experience the other day. I bumped into someone who works in our IT. This guy's a pure programmer. And he bumped into me and he said, oh, you know, we're doing our recovery, unit recovery plan. I said, well, tell me what you're doing. He said, well, we're looking at all of the data that we're collecting, and we're figuring out what we really don't need so that you can start to collect data on recovery outcomes. I said, yeah, that's great. So everyone in the organization is aligned with the idea that our goal as an organization is to promote recovery and that everyone in the organization has a role in doing that. So infrastructure. The fourth is, and again, another lesson that I learned from Tom, is that how do we tie our agenda to a broader political agenda, which is whether we're in a state or a city or whatever the jurisdiction is. And so in working at a city level, this is the first time I've ever worked at a city level, so it's been a little intense. It's much more intense than working at the state, because when you walk out your door, the issues are right in front of you. So those of you who work in the city, and you just feel it. You know, when I had to deal with homelessness when I lived in New Haven, I could always talk to the providers who lived in New Haven. Now I'm, that. So that's very different. But one of the things that has been striking in my experience here is how many people come to the behavioral health system to solve problems in their system. Child welfare, the prison system, homelessness, etc. And I think one of the things that's been really neat is how the recovery movement, I think, that's happening there. I'm starting to hear people in those other systems talk about it. And so they are starting to see that this whole recovery thing is really about something that can help them, as well as something that we see as important to us. Okay. Bill mentioned the geo-mapping. So we actually do geo-mapping of a lot of things. We know where suicides happen. We know where overdoses happen. We know where homicides happen. We know where the people in treatment. I can point to you in the communities where you have concentration of that. And one of the things that we know when you look at those maps is, if I showed you a map of the people who drop out in Philadelphia, or the people where you have the highest homicide rate, or any number of those things, they cluster in certain communities. So what that tells us is that part of our strategy has to be targeting those communities as a way of getting to people sooner, and so forth. So again, broadening the agenda. And then the last thing I will say, is the issue of using the leverage. And I'm always surprised at how both providers and policymakers, financiers of systems, don't use the leverage that we have. And I think there are a lot of levers that we have as policymakers in particular that can be used in the service of, I mean, some of them are pretty simple. There's like things like, we're going to do an RFP, and if you haven't done a recovery assessment, we didn't make it mandatory. We said it's a voluntary thing, but if you haven't done that, you're no longer qualified to apply for this money. If you don't have people who are in recovery on your boards of directors, you know, we're not there yet, but we're going to. That's at some point going to be a requirement. But we have all kinds of levers that we can use to shape the behavior that we want, and you know, I've always been surprised that we don't always use those. And so the fifth lesson is to use the levers that we have. And I'll give you one quick example. And this is again tied to that issue of how do we broaden the agenda. Major issue of homelessness in our city, many of whom are people who are addicted, on the street homeless. And you know, we got a lot of pressure. You guys got to get those folks off the street because we know that they are addicted. Now, the real issue is that people are homeless. The issue is that they don't have a home. We can get them treatment, but ultimately they need a home. And so we said, okay, fine. What we'll do is we'll take excess residential capacity that we have, and we will transform those programs to deal with people specifically who are homeless. And because we also manage the managed care entity here, and run the managed care entity here. What we said was, okay, we're going to go from what's typically a 3-month length of stay to a year-long length of stay. Now, my managed care folks, they almost dropped out of their chairs when I said that. But that's what they needed. Because we know that if you've been living on the street for 10, 15 years, you're going into a treatment program for 3 months. It's just probably not going to work. You're going to need a much longer period of time. And so being able in a position to use that leverage, and because frankly, I think we're going to save money by doing that. So it's not going to cost us any more money. So those are my top 5. I hope they're helpful, and hopefully we'll get a chance to talk about some more. Thank you.